Hello, I'm Dr. Ayub. Today I'm here to discuss a very important area in organic psychiatry, and this is also important in liaison psychiatry, that is delirium. If we see delirium is acute confusional state or acute onset of inattention, impaired level of consciousness, and disturbance of cognition in the form of being disoriented, memory impairment. The other supportive feature which can be part of delirium include a reversal of the sleep-wake cycle, perceptual disturbances in the form of hallucination, illusion, transient delusion, psychomotor disturbances like being hyperactive or hypoactive, inappropriate behavior and emotional symptom being anxious or hypervigilant. The delirium is a clinical diagnosis, and on the basis of duration, sometimes delirium is classified as acute, subacute, and chronic. The acute is usually the duration is less than 6 months, while the chronic is greater than 6 months. This is also known as the brain syndrome, acute confusional state, infective psychosis, psychoorganic syndrome. In case of delirium, we have to rule out certain other conditions like dementia, or sometimes delirium can be superimposed on dementia. And the psychoactive substances like withdrawal of alcohol can present with delirium. We have to exclude that condition as well. If we see the finding in the mental state of the patient can be hyperactive or hypoactive. Sometimes delirium is on the basis of motor activity divided into three types. If the patient is overactive, and sometimes patient is hypoactive, and sometimes patient is in between hyperactive and hypoactive. Usually, the prognosis of hyperactive delirium is better as compared to hypoactive delirium. And the orientation, the patient might be usually not oriented to time, place, person. And the emotional symptom in the form of being hypervigilant, drowsy, lethargic, stuporous, or comatose. The patient can experience hallucinatory behavior, or patient might be responding to external stimuli. The patient can be restlessness or fearful. In case of some cases of alcoholic delirium or the delirium tremens, the patient can see visual hallucination in the form of Lilliputian or small creature, and in that cases, patient even laugh. The other features of delirium on mental state, impaired memory and transient delusion, and there's a reversal of the sleep, worsening of the symptom at the night. If we see the risk factor of the delirium, they could be related to patient, they could be related to a certain medical procedure, they could be related to certain drugs. If we see the risk factor which are related to patient, being elderly or age greater than 70 is a risk factor for delirium. If patient is already having dementia or cognitive impairment, that is a risk factors for your delirium. Previous episode of delirium is also a risk factor. Patient having CNS pathology like a previous history of stroke, a previous history of other organic causes like Parkinson disease is a risk factor for the delirium. Uh, is like pathological condition which increase the permeability of the brain like CNS infection also predispose the patient to delirium. Poor nutritional status of the patient and other comorbid condition. These are patient-related risk factors which increase the risk of delirium. If we see illness-related factor, if patient is having certain comorbid condition that also increase the risk of delirium, like a very severe illness. If the patient is dehydrated, the risk of infection, especially the urinary tract infection, increase the risk of delirium in elderly. Fracture, hypothermia or fever, hypoxia, metabolic or electrolyte imbalance like hyponatremia. Patient is experiencing pain, constipation, HIV heads, burns, or nicotine withdrawal. These are all illness-related risk factors for delirium. There are certain intervention-related risk factors, like patient being in perioperative condition, certain surgeries like hip surgeries or cardiac surgeries, prolonged duration of operation, catheterization, or emergency procedure. These are also risk factors which increase the risk of delirium. There are certain environmental risk factor, for example, like patient having a visual deficit, patient having problem with hearing, or patient is physically restrained, or patient is socially isolated, stressors, immobility. These are also risk factors to the delirium. Certain medication can lead to or increase the risk of delirium, like polypharmacy, drug withdrawal even cause the delirium. The drugs which are usually notorious to cause delirium or increase the risk of delirium includes benzodiazepine or psychoactive substances, anticholinergic medication like procyclidine, anticonvulsant medication, lithium, digoxin, diuretics, NSAID, or steroid are some of the medication which increase the risk of delirium. These are some of the reasons which increase the risk of delirium. If we see a case of delirium, we know that the diagnosis of the delirium is clinical. So first of all, we have to establish the diagnosis of delirium. For that, we can take a collateral history from the informant, or we can do a certain examination like mental state examination or assessment for the orientation. And there are also certain screening tools which are used for the evaluation of the delirium, like brief cognitive assessment tool or confusion assessment method. These are some of the, and on bedside, we can do the assessment for orientation with attention. If we establish the diagnosis of delirium, the second thing we have to look for, we have to see for underlying cause of delirium. What is the risk factor or what is responsible for delirium? If this is related to some infection or if this is related to any electrolyte imbalance. So we have to do certain examination, certain investigation according to the presentation of the patient. And we also have to take the history from the caregivers, that is the collateral history. And these are some of the screening tools that I already mentioned: the confusion assessment method, delirium rating scale, or memorial delirium assessment scale. These are some of the rating scale which are used for the diagnosis of delirium. On bedside, we check for the orientation. There are some brief cognitive assessment tool we can apply in case of delirium to differentiate it from the our dementia, which include MiniCog, portable mental status questionnaire, Montreal cognitive assessment. And on bedside, we do the orientation and attention. The principle of management and delirium include maintaining the patient safety. The patient safety is the our goal, and that include the airway, breathing, circulation. The second thing, we have to treat the underlying cause. The third thing is the managing the delirium symptom, as we mentioned. the patient with delirium can present with the aggressive behavior. They can respond to external stimuli, or they can interfere the treatment or the intervention which are being given to the patient. So we have to also manage the individual symptoms of the patient to make the management of the patient smooth. So maintaining patient safety, treating the underlying cause, and treating the problematic symptoms and delirium. The patient safety, we have to consider the patient safety. We have to protect the airway. We have to hydrate and give nutritional support to the patient. Preventing skin breakdown. For that, we have to change the posture of the patient and providing safe mobility to the patient and preventing the falls. And sometimes some setup to the restraint of the patient that is usually discouraged because it increases the risk of the delirium. While the second thing, we have to treat the underlying cause. If it is related to infection, for that we have to give the appropriate antibiotic. The third thing that is important and very important and lies on psychiatry, the management of the delirium symptom. If the patient is restless, patient is aggressive, patient is hyperactive, and for that there are the treatment is two group of treatment we have. The non-pharmacological treatment to deal with the problematic symptom and delirium, and the pharmacological. First, we have to see the non-pharmacological treatment, which are important to manage the symptom and delirium. So the first step is reorientation strategies. And reorientation strategy, actually what we do, we educate the carer of the patient about the delirium and involve the carer and the care of the patient. So we encourage the carer try to reorient the patient or reassure the patient. And managing the patient of delirium and familiar environment with familiar staff also has a good impact on the symptom of delirium. And we have to normalize the sleep-wake cycle of the delirious patient. As we mentioned in delirium, there's a reversal of the sleep cycle actually. So we should discourage the daytime sleepiness and encourage the uninterrupted sleep at night. And in some cases, we can use the quiet room and with low light, and in daytime adequate lighting is necessary to normalize sleep wake cycle. The third strategy which is important to prevent the behavioral symptom which we see in delirium is maintaining safe mobility of the patient, that we have to avoid restraint. Restraint actually worsen the delirium and increase the symptom of delirium. So we should ambulate such patient 3 times a day. And along with that, the fourth thing, we have to prevent certain complications like falls, constipation, and ensure adequate pain relief. Like these are some of the reasons which increase the aggression or behavioral symptoms of the delirium. But what if in some cases of delirium, the behavioral symptoms are so severe that it does not respond with the non-pharmacological intervention, or sometimes patient experience severe psychotic symptom. So we need some medication. But as the delirium is usually seen in elderly patient, so it's a rule of thumb, we have to start medication and low dose, and we have to go slow. So the medication, the evidence support the use of certain medication in case of delirium, which are severe enough, which interfere the medical intervention. In that cases, the allopurinol is indicated, but as we mentioned, in very low dose, 0.5 to 1 milligram. It should be given orally, and some cases we can give it in IM form. But for allopurinol, we have to monitor the patient for extrapyramidal side effect, QT interval prolongation, or in some cases increase the risk of a stroke. The other medication which evidence supports the use of these medication include quetiapine, risperidone, and olanzapine. The risperidone also increase the risk of extrapyramidal side effect, or in some patients it lead to hypertension. We have to monitor that as well. In case of delirium due to alcohol withdrawal, the diazepam is used. In case of neuroleptic malignant syndrome or Parkinson, we use lorazepam. And in all delirium cases, if the sleep is severely impaired and the non-pharmacological intervention are not effective, then we can use melatonin for sleep. So there are some evidence that, as we know, the previous history of delirium is also a risk factor of future delirium. So there are some evidence by the Cochrane to how we can prevent delirium pharmacologically. So there are some evidence support the use of low-dose haloperidol, rivastigmine, or olanzapine for the prevention of delirium. So this is actually the summary. What we did in first step, we established the diagnosis of delirium, that was clinical. Second, we identify the underlying cause of delirium. Then the management, we have to maintain the safety of the patient. We have to treat the underlying cause, and we have to manage the delirium symptoms, which include the non-pharmacological and pharmacological. I hope if we see the prognosis of delirium, it usually resolves in 4 weeks, but it's also associated with high risk of mortality, that is 6 to 18%. And it leads to persistent cognitive impairment in certain cases. It also increases the risk of subsequent dementia. Thank you for listening, and if there's any question related to delirium, kindly feel free to write in the chat box. Thank you.